Today, we're going to review the new scientific statement for clinical considerations for competitive sports participation for athletes with cardiovascular abnormalities. This was published jointly by the American College of Cardiology and American Heart Association, or ACC, AHA for short. This document was published in both Circulation and the Journal of the American College of Cardiology on February 20, 2025. Because this is a scientific statement and not a clinical practice guideline, there is no formal grading system for the key directives or best practice recommendations within. This video will only cover the highlights across the 11 sections included. For the full breakdown of the takeaways and for the various figures and tables included, make sure to check out the full text manuscript published in JACC and CIRC. With that said, let's jump right into the key takeaways and clinical considerations for participation in competitive sports for athletes with cardiovascular abnormalities. Section 1 covers sports classifications, and the highlights of this section include an updated sports classification schema with removal of discrete categories of sport as shown in Figure 1. Sports classification is presented as a continuum of endurance and strength training loads. It's also presented as levels of bodily collision and impact relevant for competitive athletes on oral anticoagulation, as highlighted in Table 3. Section 2 talks about the pre-participation cardiac evaluation, and the highlights of this section include a breakdown of specific clinical considerations for the pre-participation cardiac evaluation of competitive athletes, as reflected in Table 4. Acknowledgement of the limitations of both history and physical exam and 12-lead screening ECG. 12-lead ECG screening is reasonable, as long as equitable access to expertise and a downstream process with appropriate resources are available. Cardiac imaging, exercise stress testing, and ambulatory rhythm monitoring have insufficient data to suggest incremental value for use in the primary screening of asymptomatic competitive athletes. And finally, no approach to cardiac pre-participation screening provides absolute protection against sudden cardiac arrest. Thus, an emergency action plan that includes training in high-quality CPR, prompt access to an AED, and a coordinated medical transport system should be developed, practiced, and used for all environments in which competitive athletes train and compete. Section 3 covers the ethical aspects of competitive sports eligibility, which includes a breakdown of specific clinical considerations for shared decision-making with competitive athletes, as shown in Table 5. Shared decision-making is an ethical imperative to include in the clinical management of competitive athletes, including decisions for competitive sports participation. It is the foundation of these updated clinical considerations. And finally, a stepwise approach to the implementation of shared decision-making regarding participation in competitive sports among athletes with cardiovascular disease as shown in Figure 2. Section 4 is on cardiomyopathies, and the highlights of this section include a breakdown of specific clinical considerations for competitive athletes with cardiomyopathies as detailed in Table 6. It includes the following types of considerations: general hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic cardiomyopathy, and left ventricular hypertrabeculation. This section also emphasizes that a uniform mandate of sports restrictions for athletes with all types of genetic cardiomyopathies should not be applied. Competitive sports participation may be reasonable to consider in competitive athletes with genetic cardiomyopathies. Section 5 covers myocarditis, pericarditis, valvular heart disease, and other acquired cardiovascular conditions. It includes a breakdown of specific clinical considerations for competitive athletes with myocarditis, pericarditis, valvular heart disease, or other acquired cardiac conditions, as outlined in Table 7. Resumption of competitive sports participation can be considered before 3 months of exercise restrictions in select cases of clinical myocarditis. Clinical considerations are provided for myocarditis, acute viral infections including SARS-CoV-2 and long COVID SARS-CoV-2 vaccination, incidental myocardial fibrosis, pericarditis, and valvular heart disease including mitral stenosis, mitral and aortic regurgitation, cardiac valve surgery, and mitral valve prolapse. Additionally, it covers Kawasaki disease, and infiltrative cardiomyopathies such as Anderson-Fabry, sarcoidosis, amyloidosis, and hemochromatosis. Section 6 covers congenital heart disease. Highlights include clinical considerations provided in the context of physiology and anatomy rather than specific congenital diagnoses, as detailed in Table 8. Clinical considerations are also provided for coronary artery anomalies, including anomalous coronary origins and myocardial bridging, as outlined in Table 9. Section 7 covers aortopathy, including bicuspid aortic valve and spontaneous coronary artery dissection. Highlights include a breakdown of specific clinical considerations for competitive athletes with aortopathy, bicuspid aortic valve, or spontaneous coronary artery dissection, as detailed in Table 10. Clinical considerations are provided for the approach to aortopathy in young competitive athletes. Finally, clinical considerations for aortopathy are succinctly separated into sections on bicuspid aortic valve with aortopathy and heritable thoracic aortic disease, gene positive and gene negative. Section 8 covers arrhythmias, devices, and ECG abnormalities. It includes a breakdown of specific clinical considerations for competitive athletes with arrhythmias, implantable cardioverter defibrillators or pacemakers, syncope, and asymptomatic abnormal electrocardiographic interpretation, as seen in Table 11. Additionally, there is an overview for distinguishing between low and high-risk ventricular arrhythmias, which can be found in Table 12. Clinical considerations are provided for competitive athletes who survive sudden cardiac arrest, as well as for asymptomatic competitive athletes identified with abnormal results on screening ECG. Section 9, Cardiac Channelopathies. Highlights include clinical considerations provided for the approach to competitive athletes with cardiac channelopathies, as outlined in Table 13. These considerations cover general considerations: long QT syndrome, catecholaminergic polymorphic ventricular tachycardia, and Brugada syndrome. Additionally, competitive sports participation can be considered for athletes with catecholaminergic polymorphic ventricular tachycardia who are clinically stable and under expert supervision. Section 10 covers Masters athletes. This includes an algorithm for cardiac risk stratification considerations for Masters athletes, as shown in Figure 3, and another clinical algorithm for Masters athletes with coronary artery disease, detailed in Figure 4. Clinical considerations are also provided for Masters athletes with conditions such as atrial fibrillation, myocardial fibrosis, dilated or aneurysmal ascending aorta, or chronic valvular heart disease, as outlined in Table 14. These considerations include general considerations, subclinical CAD, chronic stable CAD, acute coronary syndrome, atrial fibrillation, myocardial fibrosis, thoracic aortic dilation or aneurysm, chronic mitral and aortic VHD, and antithrombotic therapy. Section 11, Additional Cardiac Conditions and Considerations, includes a breakdown of clinical considerations for competitive athletes with hypertension, commotio cordis, or pulmonary embolus. It also provides additional clinical considerations for competitive athletes and performance-enhancing drugs or supplements, those competing in extreme exercise environments like altitude and scuba, and pregnant athletes, as detailed in Table 15. Specific conditions covered include hypertension, commotio cordis, pulmonary embolism, performance-enhancing drugs and supplements, extreme exercise environments, and pregnancy. This section also notes that competitive athletes with hypertension, in the absence of a hypertensive emergency, can continue with sports participation. Clinical considerations are provided for athletes diagnosed with pulmonary embolism, those competing at extreme altitude, or recreational athletes participating in scuba. Other clinical considerations are provided for competitive athletes without established cardiovascular disease who wish to continue competitive sports while pregnant. So there you have it. A recap of the new ACC-AHA scientific statement for competitive sports participation for athletes with cardiovascular abnormalities. For more information on this document or to access the summary or other resources, visit us online at guidelinesentral.com or download the Guideline Central mobile app, available on iOS and Android devices. This has been a Guideline Central production, and we'll see you very soon for the next one.